Very good. Welcome back. So we are going to begin our public comment session. So at the beginning, let me state that we view the public comments essential to our work, and we are very interested in hearing the comments from the public. I want to let everybody know today that the speakers that were selected by lottery from advance of the meeting. The final list was obtained today. For the speakers, it's important that you stay within the 3-minute time frame for your speech or your comments. This is essential in order to get through this period in the defined time. There will be a display on your screens, a ball that will circle through 3 different colors, and at the end will indicate that your time is up. If you, at the time you reach your time limit, I will tell you that thank you for your comment, your time has expired. If you exceed that by 15 seconds, I will state, as a courtesy to other speakers, we ask that you complete your comment, and if you extend past 30 seconds, I will ask that the microphone be cut, and will state your comment time has ended. Thank you very much. So we'll begin now, and again, we appreciate you spending time with us and giving us your thoughts. So our first speaker is Dora Rice. Ms. Rice, please state your affiliation.
Thank you. Can you hear me?
We can. Thank you.
Wonderful. So thank you for the opportunity to comment. My name is Dora Rice. I'm a professor of law at the University of California, Hastings College of the Law, and I'm grateful to the committee for all its work. I have 3 topics I want to address. First, your safety updates. Today is about Johnson & Johnson, and I'm looking forward to tomorrow's more general one, are excellent and incredibly helpful. As you know, there are anti-vaccine activists online misrepresenting the data about COVID-19 vaccines to create or increase vaccine hesitancy. I know some of you also respond to that online, and I want to thank those committee members personally for their measured, informed responses. We really appreciate you there. Among other things, anti-vaccine activists are misusing VAERS report in multiple ways and amplifying any rumor of death or harm after COVID-19, even if it's unfounded, even if it's against the fact. We can't stop them from doing that, but you can help arm us in responding to this. For example, when you provided numbers on the benefits of influenza vaccine, even with limited effectiveness, it was a powerful and helpful counter to claim that it's useless. Short material setting out, for example, death report numbers in context, background rates, causes, why you conclude that there's no link to vaccines for most of them would be helpful. Short material summarizing the complex safety data about Johnson & Johnson that you covered would be extremely helpful. A short material about VAERS report and what they mean would be helpful. And although this is not the committee, if there is a way to add to every VAERS table generated a square in the middle that mentions the limits, that would also be helpful. My other 2 comments are about allocation. First, I hope you will consider the point made during your February 24 to 25 meeting about the need to prioritize incarcerated people. As pointed out, this population has been disproportionately impacted by COVID-19, is at high risk, and may be mistreated in distribution. When you incarcerate people, you take responsibility for their needs. ACIP discussed these people early on with long-term care facilities, but it's not reflected in the guidance. Maybe it's time to revisit and redefine long-term care facilities to cover incarcerated people, for example, by redefining priority institutions as residential institutions for those who have limited ability to live. They deserve an opportunity to get vaccines if they want them. Finally, as mentioned in the last presentation, we're seeing strong inequities in access to the vaccine. That's not on you, that's not your recommendation, but maybe it's time to remind states that they need to prioritize high-heat population and bring vaccines to where people are, including people who have less access through the internet-dependent channel or less mobility, should be a priority. We need to protect everyone to end the pandemic. Thank you for your time.
Thank you very much for your comments. Our next speaker is Ms. Karen Ernst. Ms. Ernst, please, and state your affiliation.
Can you hear me?
I can, thank you.
Hello, ACIP members. My name is Karen Ernst, and I am the Director of Voices for Vaccines. A year ago, I attended ACIP in person, where Dr. Messonnier delivered an update on SARS-CoV-2 and its spread overseas. At the time, there were 80,413 cases worldwide. Today, you are discussing the third vaccine approved by the FDA under EUA to fight this virus. Thank you, and thank everybody who worked to get us here today. This single-dose vaccine elicits a lot of hope. We all know that many people who need COVID vaccines the most are often having difficulty getting them. Some of this is simple supply and demand, and some of it is distribution, and some of it is people gaming the system. My own parents were frustrated for weeks working within the system as we witnessed younger, healthier people cross state lines to access vaccines likely meant for others. An entire Vaccine Hunters Facebook group locally to me has 18,000 members and 190 posts today and works on the premise of finding vaccines via connections and rumors. We all know that these scenarios exacerbate health inequities. A single-dose vaccine that can be stored in regular vaccine refrigerators and has the potential to get more vaccines to BIPOC, rural, and poorer communities. I would get the Janssen vaccine in a heartbeat, but it has been billed as a less effective vaccine in the media already. If we put the single-dose vaccine on a bus and drive it to places where people have had access issues with other vaccines, we risk the perception that the inferior vaccine is being saved for poor people or for BIPOC communities or rural folks. We need some real, plain language, clear public education on the difference between clinical trial efficacy and real-world effectiveness. We need people to understand that the efficacy numbers put out were not on the same scale, like a standardized test. And we need people to have the absolute best medicine and the best vaccines available to everyone in an equitable way. Without this work, we risk increasing not only vaccine hesitancy, but also distrust in healthcare for years to come. Thank you very much.
Thank you for your comments. Our next speaker is Ms. Amy Pizzani. Ms. Pizzani, and please state your affiliation.
Good afternoon. My name is Amy Pizzani, and I'm honored to serve as the Executive Director of Vaccinate Your Family. Our organization was formed on the heels of the measles epidemic of 89-90 as Every Child by Two. Our co-founders, former First Lady Rosalind Carter and Mrs. Betty Bumpers, knew that even 150 lives lost to a vaccine-preventable disease were too many, and so they dedicated their lives to vaccine advocacy. We are proud to have been a part of the solutions that have resulted in a massive decline in vaccination disparities among children, although we recognize that we must continue to be vigilant and focus on ensuring that every child has access to life-saving vaccines. 30 years later, we are renamed Vaccinate Your Family and are a part of the fight against a worldwide pandemic. On behalf of all of us, I wish to thank the committee and all the staff at CDC for your unyielding commitment to stopping this deadly virus. I agree with the previous public comments with regard to the critical importance of transparency in the review of the safety data for COVID-19 vaccines, both pre and post authorization. This intense review and the sharing of safety data is of paramount importance to health advocacy organizations like ours as we prepare resources that may help increase not only confidence in vaccinations, but also COVID-19 vaccine readiness, particularly among minority communities. I also wish to thank the members of the National Academies of Medicine and ACIP work groups for the diligent work you conducted to not only research the disproportionate burden of coronavirus on various communities and ethnic populations, but also to develop the prioritization plans. Not all states chose to follow the plans, and I can tell you that based on the calls that flooded into our organization phone and email lines, particularly in the early weeks, that the overwhelming majority of calls we received from seniors desperately searching for COVID-19 vaccinations came from states that failed to follow your prioritization scheme. Confusion and chaos in those states was real, and we hope that when the pandemic is behind us, government agencies and legislators will conduct a postpartum analysis to determine which prioritization plans resulted in reduced cases and overall public health functionality. Here at Vaccinate Your Family, we paid close attention, not only to the morbidity and mortality data, but also to the plan, and we redoubled our efforts to eliminate immunization disparities, particularly among communities of color. In December, we proudly announced our partnership with the National Council of Negro Women to create the Good Health Women's Immunizations Network, which will begin in 10 states, where we will create a network of African-American women who will become COVID vaccine allies, encouraging their local communities to vaccinate against this deadly disease. We've also set our sights on developing new culturally competent resources and videos featuring experts in many languages, and we're translating our website into Spanish. We're also translating a large portion of our resources into over 6 commonly spoken languages in the United States. We wish to thank you so very much for everything you're doing. We know that you, everyone on this committee is committed to our shared mission to save lives, and we look forward to working with you now and into the future.
Thank you very much for your comments. Our next speaker is Dr. Jeffrey Silversweek.
Good afternoon. Thank you for the opportunity to address ACIP today. I am Jeffrey Silversweek, Chief Medical Officer of the Rogosin Institute in New York City. We are a nonprofit provider of kidney care, including dialysis, to some 1,500 patients. I speak today on behalf of my colleagues, the 21,000 members of the American Society of Nephrology, whose COVID-19 response team I have co-chaired for the past year, and dialysis providers, large and small, for-profit and non-for-profit, across the United States. Most importantly, I speak on behalf of the 500,000 Americans with chronic kidney disease who depend on life-sustaining dialysis treatments. By virtue of their primary condition and the invasive nature of their ongoing regular care, these individuals, when infected with SARS-CoV-2, are at higher risk of serious COVID, requiring hospitalization and of mortality than age-matched Medicare beneficiaries. Dialysis patients must go out into the community 3 times weekly for 4 to 6 hours each time. They do not have the option of sheltering at home, increasing their risk and the risk of those in their family and community. Patients with chronic kidney disease are disproportionately African American, Hispanic, and Native American. They experience the effects of lifelong health disparities, heightening their susceptibility. Data show they have a higher risk of acquiring COVID and of more severe complications from it due to their multiple comorbid medical conditions. In the US and around the world, mortality rates of dialysis patients with COVID range from 20 to 40%. The dialysis community has committed to working together to ensure that patients and staff get vaccinated if vaccines are allocated. Because our patients are treated 3 times weekly, administration of the second dose is less problematic than in most patients. Because of the long-standing, trusted relationship between dialysis patients and the staff who care for them, we have consistently had high rates of vaccination against infectious diseases like influenza and hepatitis B. Our patients are less likely to be able to register online for vaccine appointments because of their medical and socioeconomic conditions, and are less likely to be able to wait in line for vaccination. I do not envy the responsibility you carry in recommending who merits priority for vaccination, but I ask that you consider that dialysis patients are like daytime congregate care facility patients with similar mortality, so should be prioritized like residents of long-term care facilities. They are among the highest risk groups of dying from COVID. I beseech you to provide an allocation of 500,000 doses of vaccine to allow dialysis providers to protect these mostly Black and brown patients. Thank you for your time today.
Thank you for your comment. Our next speaker, Mr. Roisin McLaughlin. Mr. McLaughlin. We will come back. Let me move on to the next one. Dr. Albert Farah.
Good afternoon. My name is Dr. Albert Farah, and I'm the Vice President of Clinical Affairs at the Cystic Fibrosis Foundation. On behalf of the Foundation and the more than 30,000 people with CF in the United States, I would like to thank the committee for the opportunity to provide comments regarding development and allocation of COVID-19 vaccines. The CF Foundation is a national organization actively engaged in the research and development of new therapies for CF, a rare, life-threatening genetic disease characterized by thick, sticky mucus in the lungs, resulting in frequent acute and chronic respiratory infections. These chronic airway infections are punctuated by pulmonary exacerbations, events often triggered by respiratory viral infection that are a risk factor for an irreversible decline of lung function and associated with morbidity and mortality. Continued progression of the disease can result in advanced lung disease so severe that lung transplantation may be the only life-extending option. COVID-19 represents a serious threat for people with CF. The CF Foundation Patient Registry collects information on the health status of people with cystic fibrosis who receive care in CF Foundation accredited care centers. The data underscores the threat this infection poses to people with CF. A published global analysis of 181 COVID-19 cases among people with CF demonstrated CF patients with advanced lung disease and those who are post-lung transplant are at increased risk of severe outcomes, including death. We recognize that to date, the ACIP included those with high-risk conditions as a prioritized group in the committee's COVID-19 vaccine allocation recommendation. And we are pleased that these recommendations are accompanied by language from the CDC about using individual clinical judgment to identify patients whose risk factors warrant priority vaccine access. However, we are deeply concerned about the wide range of interpretations of ACIP's recommendations among states and localities, in some cases not including rare diseases like CF on lists of prioritized populations, and in other cases, opting to use age-based criteria alone. The desire for simplicity must not come at the expense of those who are most vulnerable to the consequences of this infection. People with CF and others with high-risk conditions must be prioritized for early access. Some current state and local practices run counter to ACIP's intent of prioritizing those at highest risk of morbidity and mortality and are placing people with CF and other underlying medical conditions at greater risk solely for the sake of expediency. We urge the ACIP to provide clarifying language on phase 1C recommendations for rare disease populations to ensure that high-risk patients with diseases like CF are able to gain early access to COVID-19 vaccines. Thank you again for your attention and consideration of people with CF as you tackle these critical issues.
Thank you for your comments. Let me turn back to Mr. McLaughlin. All right, I'll come back. Let's go on to Mr. Jonathan Brand.
Thank you. My name is Jonathan Brand, and I am president of Cornell College in Mount Vernon, Iowa. I'd like to offer an idea. Using the one-shot Janssen vaccine right now to target a population that as a group moves around the most, the 53 million 18 to 29-year-old population, which includes college and university students. In fact, at over 30 million, 18 to 24-year-olds are also a group highly likely to live in congregate settings, residence halls, and apartments, an environment that greatly increases spread. A strategy that relies on colleges and universities to vaccinate all 18 to 29-year-olds, not just our students, could jumpstart a second front against COVID. Vaccinating those ages 18 to 29, some of our biggest spreaders, will dramatically accelerate reaching herd immunity. In addition, colleges and universities can be set up as mass vaccination sites, inoculating thousands of individuals in this cohort in short order, rather than further taxing current mass vaccination sites. We have the gyms, the arenas, the field houses, the parking lots. And because schools of higher education are located all over the country, in urban, suburban, and rural settings, we can increase access. We are everywhere. Fortunately, the Janssen vaccine does not need special cold storage. And because it's a one-shot deal, this vaccine resolves a logistical challenge we'll soon confront: a group that tends to relocate throughout the country in May or June and won't be able to easily return to the same location or state for a second shot. Finally, because 45% of those ages 18 to 24 work in retail and leisure hospitality, industries where we've been concerned with COVID transmission and the harmful economic impact of COVID, this vaccination strategy can only help to jumpstart those sectors as we return to normalcy. Some believe my idea would encourage reckless behavior post-vaccination. I don't believe that. I'm not seeing 20-year-olds at bars and restaurants any more than older populations. At Cornell, we currently have a 0% student positivity rate and cumulatively 1.6% because our students, like so many others, are willing to sacrifice. I am confident that this will continue until you tell us we can relax our protocols. States should continue their current phases with the Pfizer and Moderna, but they should plan to concurrently mass vaccinate all 18 to 29-year-olds with the Janssen vaccine. And higher education can help get this done now. Thank you.
Thank you for your comments. Our next speaker is Mr. Eugene Jackson. Mr. Jackson.
Yes, can you hear me?
Yes, we can.
Okay, my name is Eugene Jackson, and I'm currently a PD dialysis patient in Waco, Texas. And I want to thank you for giving me the opportunity to voice to give my voice. We currently know that I also am an African American male, and I represent the African American community as well as the dialysis community. We know that and understand that African Americans and Hispanic have disproportionately been affected by COVID-19. African Americans are 1.9% more likely to have COVID-19, and also Hispanics are 2.3% more likely to be affected by COVID-19. Our communities have been ravaged by this dreaded disease, and the only way we see fit to protect us is by vaccinations. And although I appreciate the effort that we are being vaccinated, but also that it seems to me that we seem to be further down the line to be vaccinated. If we are such a high risk, it would seem to me that we should be more likely to be one of the first ones to be vaccinated. And I understand that it's up to each state to disseminate the vaccinations as they see fit. But I just wanted to get an understanding of why is it that those who have such mobility conditions seem to be so far down the line. If we know that we are so disproportionately affected by this dreaded disease, then why are we so haphazardly down the line to be vaccinated? And I appreciate the effort that's come about from the CDC and the ACIP to get the vaccinations out. But I just hope that in the future that these people become more of a priority. Thank you.
Thank you very much for those comments. Let me go back and see if Mr. McLaughlin is able to join us. Okay, well, I'll come back to you again at the end, Mr. McLaughlin. Next, Dr. Michelle Biscus.
Good afternoon. I'm Dr. Michelle Biscus. I'm the medical director of Tennessee's Vaccine Preventable Diseases and Immunization Program, and I'm also a board-certified pediatrician. I'd like to thank the committee for all its work during this challenging time. The work you do has never been more important to the health of this nation, and we all owe you a debt of gratitude for sacrificing your time to ensure that the COVID-19 vaccines that have been granted emergency use authorization are administered based upon sound research and science. It's easy to lose sight of the tremendous magnitude of this pandemic, which is far and away the most significant infectious event ever to impact the world in more than a century. It has justifiably impacted every aspect of our lives. More than 500,000 Americans are dead, 41 times the number of lives lost during the 2009 H1N1 pandemic. More than 28 million, nearly 1 in 11 of us, have been infected by the SARS-CoV-2 virus. 13% of those cases are in children. That amounts to 1 out of every 25 children in the United States having been infected with this virus, the long-term outcomes of which are still unknown. It's likely reasonable to assume that the more than 2,000 children who have gone on to develop multi-system inflammatory syndrome in children, or MISC, will have their lives shortened by this disease. Early studies have indicated that more than half of these children suffer heart damage, 70% suffer acute kidney injury, many requiring dialysis. While it's true that children tend not to die from acute COVID-19, how many more children will suffer the chronic effects of this disease? And yet children will be the last to be vaccinated, in part due to their lower risk of acute morbidity and mortality, but most importantly due to the lack of an authorized vaccine. It is critically important that the vaccine manufacturers make progress in pediatric COVID-19 vaccine trials as quickly as possible, not only to prevent infection, but to achieve herd immunity. As children comprise nearly a quarter of the U.S. population, being able to vaccinate children against SARS-CoV-2 is crucial to our ability to achieve herd immunity in this country. In the meantime, we need every qualified individual to say yes when offered a COVID-19 vaccine, no matter the vaccine, and do their part to end this pandemic. And we need to work tirelessly to earn the trust of those who are hesitant, especially our Black and Hispanic brothers and sisters, so that these populations that have been disproportionately impacted by COVID-19 will also accept this truly remarkable opportunity to protect themselves, their loved ones, and their communities against this terrible infection. Thank you again for your dedication to this work.
Thank you for those comments. Our next speaker will be Mr. Ben Vanzo.
Thank you. My name is Ben Vanzo. I appreciate the committee members for your service. I am the Senior Health Policy Analyst with the National Immigration Law Center. We are the primary advocacy organization working on behalf of low-income immigrants, particularly engaging on health and benefit issues. We have a long history of working to protect the health rights of immigrants, including through a network of community and legal advocacy organizations. There are over 22 million non-citizens living in the U.S., and they have been disproportionately serving on the front lines of this pandemic. The ACIP and CDC have worked hard to prioritize different populations based on risk factors, such as being frontline workers, yet being eligible for a vaccine is not much use if you face deep barriers to accessing it. We have seen from our partners and media reporting that many immigrants face numerous barriers to accessing the vaccine. Because many communities of color have high rates of foreign-born individuals, we cannot address racial equity without addressing immigrants. I want to address a few of those barriers that this committee can play a role in addressing. First, we did send comments to the committee and your December meeting because we're concerned that immigrant-heavy industries like food and agriculture production may be left out of state definitions of essential workers. These can be isolating places to work that have seen many outbreaks, like meatpacking plants, and also house workers in congregate settings. And workers may be unaware of their eligibility for a vaccine, even if they are technically included in that definition. We're also very concerned about attempts to ask vaccine recipients for identification documents. Many immigrants, particularly low-income ones, lack such documents. Well-intentioned efforts to require proofs of residency, place of work, or medical status may exclude those communities. Asking for an email harms those who are less educated or who have low technology literacy, and asking for social security numbers for the uninsured deters many from getting the vaccine. The goal is to get as many shots into arms into the high-risk populations possible. We should not be creating barriers. We need clear standards to vaccine providing entities and states that they cannot deprioritize anyone based on their immigration status, which we have seen both political leaders declare intentions to do and providers denying people because they are undocumented. These events are spread by social media and by the news and can overpower important messages coming from public health officials about the vaccine to communities. We must provide clear information in language, in as many languages as possible, to immigrants about the availability of the vaccine, the fact that their immigration status does not preclude them from getting it, and from the fact that their data is safe. Thank you very much.
Thank you for your comments. Our next speaker is Mr. Robert Longhorn. Mr. Robert Longhorn. Is Mr. McLaughlin available? Mr. McLaughlin? Okay. Let's go back to Mr. Robert Longhorn. Are you on, Mr. Longhorn? Okay, that ends our public comment session for today. I want to thank all the public speakers and ask for your forgiveness if I mispronounced your name. We'll go on now to the discussion of Dr. Oliver's presentation, Evidence to Recommendation Framework.
This is Dr. This is Dr. Oliver. Happy to answer any questions about the Evidence to Recommendation Framework.
So this presentation is open for comments or clarifying discussion. Dr. Goldman, please.
Thank you, sir. Comment first and a question. I just want to say that regardless of what the committee ultimately decides, I think if this vaccine is approved for recommendation by ACIP, we need to be very clear on our messaging regarding the comparison or lack of comparison to other vaccines, and that in and of itself, this appears to be a very effective vaccine, safe with good data, as we want to make sure that the public understands that the best vaccine is the one that they can get access to. And I really encourage governors and other jurisdictions to really adhere to the ethical framework so that we can get the vaccine out to the most people as possible. And finally, as a primary care physician, many of us are eager to be able to vaccinate our population. I think this vaccine may be very helpful in achieving that goal with the refrigerator stable storage. That being said, I do have a question. If you could, and once again, Dr. Oliver, great presentation as always, can you talk more about the thromboembolic events that were reported in any more detail? Do we have any more information on
this? Yeah, I would probably defer to either somebody from Janssen or Dr. Fink to provide the FDA overview of those. Is there somebody from Janssen that can comment on that?
Hi, yes, this is Dr. Dougie. And maybe if there's specific questions I can answer. I mean, we have observed a slight imbalance in the thromboembolic events, although it's not a big difference between groups. And as I mentioned earlier in my presentation, we have seen a large proportion of the participants who had these events had predisposing factors, underlying medical conditions that very much plausibly could have contributed to these events. So right now, we don't think that there is a causal association with the vaccine. However, we've committed to monitor this post-authorization, which is starting now, of course. And as the vaccine is rolled out, our intention is to make sure that we closely look at these events, and keeping in mind, too, that COVID-19 is also an underlying factor in terms of these events that we will have to include in our assessment.
Thank you very much. Dr. Long.
Yes, I would just like, thanks again for the work group that has done this so very well. And I appreciate their judgment that the level of confidence in the prevention of asymptomatic infection is tempered by low numbers. And I think that is important for us to remember, because it would be the opposite of every instance that we know that the more severe disease that is trying to be prevented with basically IgG antibody that is derived from an intramuscular injection, it prevents more invasive and more serious disease better than it does upper respiratory tract or asymptomatic disease. So this would be great news if it did prevent some asymptomatic infection and especially transmission from that. And I appreciate that the work group concludes that the confidence in that is not high. And then a question for you, Dr. Romero. To discuss these vaccines one against another or one compared with another and nuances of recommendations, I'm especially appreciative of some of the public comment as I had been thinking about some of these things and the age groups and the difficulty in getting to some populations. Are we going to put that off till tomorrow and today focus on the recommendation with the question in front of us?
So thank you for that question. So our mandate is to, as you know, make recommendations regarding this specific vaccine and each specific vaccine as it comes forward. We're not at this time tasked with comparing the two, 3, or 4 vaccines and coming up with specific recommendations for each one independent of the other. We can discuss this again tomorrow, but at this moment, that is not a decision that we're ready to make and certainly can discuss into the future. I hope I've answered your question.
You have. Thank you.
Dr. Dushan.
Thank you. I am very appreciative of the presenters for highlighting that it's inappropriate to try and directly compare the 3 available vaccines with respect to effectiveness. It's clear they all provide a high level of protection against what's most important, which is severe illness, hospitalization, and death. It does seem to me, however, that we may be able to compare the reactogenicity, and particularly the severe and grade 3 systemic reactions among the available vaccines. And it appears to me that the J&J vaccine has significantly fewer such reactions, severe reactions. I'm wondering if someone would care to comment on that aspect of this new vaccine. Thank you.
Thanks, Dr. Dushan. I think we would also caution against, so even comparing reactogenicity very much depends on how it was asked in the trials, the number and type of symptoms that were asked. So we would still caution against comparing, specific percent or proportions, even in reactogenicity across the trials. We will, closely monitor as these vaccines are rolled out, and we have kind of post-authorization safety data, and we'll happily bring that to ACIP as we have that available.
Thank you. Dr. Eckert.
Thank you very much. On behalf of the American College of OBGYN, I just want to state that I am very happy that Janssen has some data for this pregnancy, for this vaccine being used in pregnancy with the Ebola platform. And while acknowledging that information is present in the VRPAC and that is available publicly, I just want to know when there is going to be an opportunity to have this published, as pregnant women are very interested in safety data about this vaccine, as we all are. Thank you.
Dr. Eckert, do you mean the results from the Ebola pregnancy trials, when those may be published?
Right.
Okay. That I would defer to Janssen to answer that.
Hi, this is Makaya Duogi. Thanks for the question. These studies are ongoing. One of the studies that I had mentioned earlier, ongoing in Rwanda, is going to randomize 2,000 individuals, and that's very much in the early phases of enrollment. So it will be some time before we actually have infant outcomes and so on. So we of course are very much committed to publishing as soon as we can. And also just to mention within the context of the COVID-19 program, we will make every effort to publish data, perhaps even interim. We'll be doing an open label study. So as we have relevant information, we'll make attempts to publish as soon as we can.
Thank you very much. Are there any other comments? Again, because I brought this up, I want to point out that while I agree with the acceptability as stated for key stakeholders, we still need to really have the Indian Health Services and other stakeholders from that group and their advisors weigh in on the acceptability of this vaccine for Native Alaskans and American Indians. So with that, then I think I'll stop. Oh, yep, Dr. Dushan, your hand is still up. Did you have another comment?
No, sorry, taking it down.
Sure, I'm just making sure that I'm not skipping anyone. Very good. Okay.
Appreciate that.
Okay. So this is the policy question for further discussion. I will read it for the sake of everyone in case some do not have video access to this. So the policy question is, should vaccination with Janssen COVID-19 vaccine, 1 dose IM, be recommended for persons 18 years of age and older under an emergency use authorization? Open for questions, discussion. I'm going to give this back to Dr. Oliver, and she's going to move us through.
Thank you, Dr. Romero. So this is the policy question that we discussed. Next slide. Just wanted to remind that these were the work group interpretations of the data based on evidence to recommendation and grade. Next slide. So the vote language for the interim recommendations is on the slide. The Janssen COVID-19 vaccine is recommended for persons 18 years of age and older in the U.S. population under the FDA's emergency use authorization.
We are open for discussion or questions regarding this. Dr. Weiser.
Hi, Dr. Romero and the committee. Thanks for raising the question on behalf of American Indians and Alaska Natives. This may be a question or comment directed more toward Johnson, which is it seems that the lower efficacy that was mentioned is really a relation to the small number of participants and the small number of cases in the analysis. My question would be whether or not there are additional people who are enrolled but who don't have enough time in the study who have been included in the FDA application. And then secondly, just a comment that, considering that these lower efficacy estimates might really be related to small numbers, in our discussions on the vaccine task force, the IHS, and among others here, so we really do believe that there's a place for this vaccine, and many other people have already mentioned cases and times where this vaccine would be more acceptable to administration, such as the mass vaccination campaign, as well as the logistics around easy distribution and administration in offices and clinics. So we do feel that there would be a place for this vaccine, and it would be used, and we already anticipate using the vaccine in accordance with the other ACIP authorized vaccines. Thank you.
Thank you for those comments. Dr. Long.
It's a question, Dr. Romero, about the use of the term interim recommendations. Understanding that everything about coronavirus could change with new science and new data, is this an interim recommendation solely because it's an emergency use authorization?
Dr. Long, yes, it is. It's because of the EUA.
Thank you.
Are there any other questions or comments from the voting members or from liaisons, please? Ms. McNally.
Can someone just confirm for me that VSafe has been adapted to accommodate this vaccine? Thank you.
This is Dr. Cohn. Yes, VSafe is being adapted and will be able to enroll in VSafe in the same way that we enroll for the other two authorized vaccines.
Thank you.
Thank you, Ms. McNally. Anyone else? All right, seeing no further comments or questions, may I please have a motion to accept the interim recommendation, and I'll read it. The Janssen COVID-19 vaccine is recommended for persons 18 years of age and older in the U.S. population under the FDA's emergency use authorization. The first hand I see go up was Dr. Palin. Do you make a motion?
I do make a motion to accept. Thank you.
The second hand I see go up is that of Dr. Lee. Dr. Lee, do you have a second?
I second.
So I'm going to ask everyone to please turn on your videos so we can make this vote.
This is Pablo.
Yes.
I'm hearing that you cannot start your video because the host has stopped it.
Well, we can see.
Can you see me?
We can see.
Yes.
Yeah, Pablo, we can see many of you already.
Can you try again, Dr. Sanchez? We just undid you.
I'm not sure. Can somebody in the audience tell me if you can see me? Because we had some.
No, this is Carol Hayes. I don't see any of the faces normally at the top of the window like we usually do.
I'm sorry, but actually, I think I can now see Pablo Sanchez and a number of the other ACIP members. So I think we're actually in good shape. I don't know about you, Dr. Romero, though.
Yeah.
I don't. Oh. Yeah.
Now I can see them.
Yes, we can see you also.
We had some technical difficulties here with the Wi-Fi, so I'm using broadband. All right, and I'm not sure how well I show up on this because I can't see myself. So I have my mask on because I'm in a room with a number of CDC people, and I will take my mask off at the time of the vote. So just a second.
And everyone, this is Amanda. Before we vote, I just want to remind everyone to please indicate if you have any conflicts of interest. If you have, indicate again. And if you did indicate that you had a conflict of interest, recuse yourself from the vote as indicated. Additionally, I just want to let everyone know that Dr. Alt has not been able to attend today, so will not be voting. And Dr. Fry too?
Dr. Fry.
And Dr. Fry. So we will have a total of 13 members voting with potential for recusal as well.
All right, I think we're ready to proceed. Let me begin alphabetically. Ms. Bata.
Ms. Bata, no conflicts, yes.
Thank you. Dr. Bell.
F. Bell, no conflicts? Yes.
Dr. Bernstein.
Frank Bernstein, no conflicts, yes.
Dr. Chen.
Chen, potential conflict of interest. I will not vote.
Dr. Chen, can you, rather than not voting, recuse yourself?
Yes, sorry, I will recuse myself from voting.
Thank you. Dr. Daly.
Matt Daly, no conflicts, yes.
Dr. Cotton.
Camille Nelson Cotton, no conflicts, yes.
Dr. Lee.
Lee, no conflicts, yes.
Dr. Long.
Sarah Long, no conflict, yes.
Ms. McNally.
McNally, no conflict, yes.
Dr. Paling.
Paling, no conflicts, yes.
Dr. Sanchez.
Pablo Sanchez, no conflict, yes.
Dr. Talbot.
Talbot, no conflict, yes.
Dr. Romero, no conflicts, yes. Have I missed any of the voting members? Hearing none. Dr. Cohn, we have 12 in favor, 1 recusal, no nays. The interim recommendation passes. Over to you.
Great. Thank you, Dr. Romero. We accept the interim recommendation, and this will be delivered to the CDC director for consideration.
Can we open it up for comments from the group?
Yes.
So if any of the voting members wish to make comments, you may do so. And if you wish to close your video link, you may. I see Dr. Talbot's hand is up.
It's not up, but thank you.
Okay, thank you. I'm just looking up there. Let me see if anybody else. Dr. Daly, please, go ahead.
Yes, I just have a couple sort of overarching comments. You know, I was reflecting on the introduction that Dr. Bell provided us and just really the scope of the tragedy. But I think in the midst of this tragedy, we do have some reason for optimism. You know, I was reflecting that sort of a very common greeting in the world has been, have you eaten today? And that's reflecting this fundamental human need. But I think that now the most common greeting is, have you gotten vaccinated? You know, people are intensely concerned about where they are on the prioritization list, and that's been a very complicated thing. You know, but I think people really want to get vaccinated as soon as possible to protect themselves and to protect their families. And so, you know, I think this may be in many ways an obvious point, but I just want to state explicitly how very grateful I am that we now have 3 safe and highly effective vaccines, and just remind us all that if we use all supplies of all 3 vaccines, then everyone essentially moves up on whatever prioritization list that they're on. So I just think for that we should all be very grateful.
Thank you very much, Dr. Daly. Dr. Lee.
Thank you, and I really appreciate Dr. Daly's comments. I wanted to just re-emphasize the point that was made earlier today around the life expectancy having dropped a full year overall, but disproportionately for Black and Hispanic patients by 2.7 years and 1.9 years respectively. And also sort of in parallel comment on the challenges we continue to face with regard to both equity and access, and the substantial variability that continues to occur by state and in some instances by county. what those numbers mean to me is that we need to continue to ensure that equity is at the forefront of how we implement and think about doing that systematically. It also means that, I think that the disproportionate difference in life expectancy, to me, is not specific by age. It's really reflecting the overall burden of disease in the population. And so, I really, again, recognize all the implementation challenges that occur, but, behoove us all at the national, state, and local levels, and those of us who are practicing as well, to continue to try and keep equity at the forefront, recognizing the differences in implementation challenges, and also that there is not one right way to implement it, but we need to continue to be vigilant on this point. Thank you.
Thank you. Are there any other comments? Then seeing none, I want to thank the members of the COVID-19 work group, the chair, the co-leads, and all members of the group for the work that they put in to come to this vote today. And I'd like to thank all the voting members and liaisons that, again, are giving up of their time on a weekend. We know this is a very heavy, intense schedule for you, and it cuts into your personal time and your time with your families. But again, thank you very, very much for doing this. If there are no other comments from our executive director, which I see there are not, then I will gavel us to a close. We will adjourn tomorrow. We will come together tomorrow at 11 o'clock Eastern time for the second day. Thank you all very much. Please take care and be safe. Closed.